Okay, so organization in the heme shows that erythropoesis and megakaryopoesis, also known as thrombopoesis. Megakaryopoesis is also known as thrombopoesis, okay, occur at the same level inside the hemopoietic inductive microenvironment closest to the ablumina, that's the inside of its surface, and lymphopoiesis occurs in the core area, while granulopoiesis is in between erythropoiesis and megakaryopoiesis and lymphopoiesis. Okay, so granulopoiesis is also the same thing as myelopoiesis. You have what white cells are differentiated into granulocytes and agranulocytes. Why are they called granulocyte and agranulocyte? Because some have granules and some do not have granules. The ones with granules are, for example, like which one have granules? Granular ones: neutrophils, eosinophils, basophils. Sometimes monocytes is considered as granulocytes. What about the agranulocytes? Monocytes and lymphocytes. Okay, so we'll talk about stem cell now, having talked about microanatomy of the bone marrow and the hemopoietic inductive microenvironment where hemopoiesis takes place. Okay, so stem cells are cells with extensive self-renewal and proliferative potential, coupled with the capacity to differentiate into progenitor of all the blood cells. It can regenerate itself and it can also differentiate. A stem cell can differentiate into white cell, can differentiate into platelets, can differentiate into what? Red cell. It can also renew itself. Okay, it can renew, produce more. Okay, that's the definition of a stem cell. Okay, so but we are talking about hemopoietic stem cell here. Don't make the mistake. So stem cell can be hemopoietic, meaning that they can regenerate themselves and can also produce progenitor cells that are blood components. You could have stem cell that can regenerate itself and then produce liver cells. You could have stem cell that can, so it, science will come to a time when you don't need to donate kidney again. It will come to a time, if you have liver failure, you don't need to donate your liver. What they just need to do is to harvest stem cell that can produce liver cells and then transfuse that stem cell into someone who has liver failure, and then the stem cell will migrate itself into the liver and will start to produce new liver. We have not reached that level, but we have reached that of hemopoietic. In hemopoietic stem cell, we can harvest stem cell, like I've said, from the peripheral blood and then transfuse that stem cell to somebody who has a bone marrow failure. The stem cell transfuse, by unknown reason, will just find its way into the bone marrow of the person with a marrow failure and will start to produce normal red cell, normal white cell, normal platelets. Okay, so I hope you are following me. We are on the same page. Okay, so example of stem cell pool is pluripotential. That's why it's pluripotential, has many potentials. Stem cell, okay? And that's the hierarchy in hemopoiesis. Talk about hierarchy. Okay, so hemopoiesis consists of a series of events wherein the hemopoietic stem cell mature into functional, okay, blood cells, okay? Like you are aware, it could be erythropoiesis, let's say, it could be myelopoiesis, and it could be thrombopoiesis or megakaryopoiesis, okay? So like I said, we cannot discuss myelopoiesis today, cannot discuss megakaryopoiesis or thrombopoiesis today, but we discuss erythropoiesis, okay? Erythropoiesis, which is the formation of red blood cell. Okay, so this is the hierarchy, okay? From this single hemopoietic stem cell, this is a pluripotential, it's called a pluripotential stem cell. You can have progenitor cells directly from the pluripotential stem cell, and the progenitor cells will give rise to precursor cells, and they all have names which you have identified, okay? So from pluripotential stem cell, no, don't forget it has ability to regenerate itself and also has ability to proliferate into progenitor. That is the characteristic of a stem cell. It must have ability to regenerate. You know, it must also have ability to proliferate. So it's going to proliferate into common myeloid progenitor cells and common lymphoid progenitor cells. Okay, so these are the progenitor cells. This is progenitor. So this is stem cell. These are progenitor cells, and the common myeloid progenitor cells will give rise to all the types of the myeloid series, which are usually the granulocytes. Okay, but there is an in between cell between the progenitor cells and your red cell, your white cells, your platelets. It's called a myeloblast or erythroblast. Erythroblast is between common myeloid progenitor cells and what cell? And red blood cells. So myeloblast is between common myeloid progenitor cells and, how can it be red blood cell again? Your mind is not, yeah. Okay, so there's also a common lymphoid progenitor cells arising from where? Pluripotential stem cell, but the difference between a progenitor cell and a pluripotential stem cell is what? Reduced ability to regenerate. Progenitor cell cannot regenerate itself, unlike stem cell, but they can proliferate, they can move forward, but cannot reproduce and produce itself. That's the difference. A progenitor cell, what's the difference between a progenitor cell and a stem cell? Reduced ability, limited regenerative capacity. Which one has a limited regenerative capacity? Can you give an example of progenitor cells? Common myeloid progenitor cells and common lymphoid progenitor cells. So the common lymphoid progenitor cells will also proliferate into a lymphoblast, okay? And a lymphoblast will proliferate into lymphocytes. And we know the various lymphocytes from physiology. What are the various lymphocytes? B and T. B and T. When you taught this in physiology, you are taught stem cell, eh? Stem cell, progenitor cells. You are taught. You are taught. Okay, so it's not new. Okay, so this is the another scheme of Haemopoesis. You can see your pluripotential stem cell, myeloid stem cell, lymphoid stem cell. Your myeloid stem cell will give rise to granulocytes, monocytes, stem cell. Is that a pluripotential stem cell or progenitor stem cell? Granulocyte, monocyte stem cell. Is it a pluripotential or a progenitor cell? Yeah? Progenitor cells. So your granulocyte macrophage stem cell will now give rise to granulocyte stem cell and monocyte stem cell. Okay, they are also progenitor cells. The granulocyte stem cells will now give rise to neutrophils, eosinophils, your basophils. Your monocyte stem cell will give, these are the precursor cells. The in-between cells are the progenitor cells. And the topmost is the pluripotential. Are we on the same page? Okay. And I will tell you the reason. So in a plastic anemia, when there is bone marrow failure, you have reduced production of white cell. There is an injection now called figastrine. This has been synthesized. The granulocyte colony stimulating factor has been synthesized in the lab that you can give the person, and then it's going to stimulate production of white cell. Can you appreciate the importance now? GCSF can be given as an injection. It has been cloned. The amino acids that contains this, the DNA, the amino acids, have been identified and synthesized in form of an injection called figastrine. And then you can give in case of reduced white cell. And that was what has happened to erythropoietin too. Erythropoietin has been identified. The amino acid it contains in that order from the beginning to the end are known, and then you can synthesize the amino acid and make it in form of an injection. Why will you want to give erythropoietin? To when there is anemia, when there is reduction in production of blood. Where is erythropoietin produced in the body? Where is it produced in the mostly in the body? It's in the kidney. So individuals with chronic kidney failure, chronic kidney disease are perpetually anemic and are blood transfusion dependent because the kidney is bad and cannot produce erythropoietin. So they are routinely giving erythropoietin injection to reduce the rate of blood transfusion. Are we on the same page? Does it make sense to you? So similarly, there is thrombopoietin injection now. Thrombobag is called, and caps and tablets, that if you have challenge with your platelet count, you can take thrombopoietin injection, which is similar to erythropoietin, and then the body will start producing platelets. Are we on the same? Do you appreciate this now? Okay. So like I said, pluripotential stem cell, it is of single cell origin. It is clonal. It has capacity to differentiate into multiple stages. We have said that, okay? And it has extensive proliferative capacity. It can differentiate into all the progenitor cells, okay? And then it has ability to self-renew. It can renew itself, okay? That's why it is a pluripotential stem cell. So this is, it can renew and can differentiate. You can see self-renewal, it can self-renew itself, and then it can differentiate into progenitor cells like common myeloid and common lymphoid, okay? But what about the progenitor cells? They have reduced ability to self-regenerate. They are called burst-forming units. And burst-forming units, erythroid, and colony-forming cells. Okay, progenitor cells is the differentiated product of pluripotential stem cell. Are we on the same page? And that has restricted its lineage to either myeloid or lymphoid. Okay, it has restricted its lineage and has little or no self-renewal ability, but can proliferate. Does that make sense? Can proliferate. Okay, so as they mature, progenitor cells are eventually become restricted to single blood cell lineage called precursor cells. Okay, called precursor. So how many type of cells have we mentioned there? Pluripotential, progenitor, and precursor cells. So characteristics of progenitor has no morphological appearance, just like stem cell. You cannot look at stem cell under the microscope and say, ah, this is a stem cell moving about. No, no morphological. So how did they discover it? But if you see a neutrophil, you can say, okay, this is a neutrophil. So what will you see and say this is a neutrophil? How does it look like? It has, number one, granule. It has granule. It is multinucleated, and then so that's morphology. But for progenitor cells and pluripotential stem cell, they are not morphologically identifiable. So we use markers to identify them, called CD, cluster of differentiator markers. You cannot look at them and say, okay, this is a precursor cell, this is a common myeloid, I can see it's blue, it's black. No, you cannot. They are not morphologically identifiable. Unlike, but apart from that, it has limited proliferation and differentiation ability. So lie between the stem cell, that's the pluripotential, and then the precursor or maturing cells. Okay, so they are pronormoblasts, or that's megacardioblasts, or myeloblasts, or erythroblasts, before you get the different cells. So it can, the precursor cells, rather, the precursor cells are pronormoblasts, which are the megacardioblasts, myeloblasts, erythroblasts. They can be identified morphologically. If you aspirate the marrow, you can say definitively, this is, we are trained to identify megakaryocytes or megakaryo. We know how it looks. Okay, we are trained to recognize myeloblasts, so they are morphologically identifiable. Okay, unlike progenitor cells or pluripotential stem cells. Okay, we know that the arise from progenitor cells has only proliferative ability and cannot differentiate. I'm talking about the megakaryoblast, cannot regenerate itself. It has to rely on a pluripotential stem cell. So what are the sites of hemopoiesis? Like I've told you, there are various sites depending on the gestational age of the fetus. Between 0 to 2 months of gestation, when the lady will say, I've not seen my period, blood has started forming in the baby, in the yolk sac. Okay, by the time you miss your period, the blood of the fetus has started forming in the yolk sac. Okay, but as the pregnancy progresses, between 2 to 7 months, then this liver and the spleen have developed and then take over blood production from the yolk sac. Okay? So, but by the time the baby is ready to come to the world, between 5 to 9 months, then it switches over to the marrow, but not necessarily central skeleton. So it can be peripheral, like the is it the humerus and then the radial. Okay. So in infants after birth, it is the bone marrow of all the bones. Okay. So these are the sites, and then in adults, the vertebrae, we've mentioned it, the ribs, the sternum, the skull. So if you want to do bone marrow aspiration in an adult, which sites do you think we should use? The liver, the spleen. Which sites? If you come to hematology, we do bone marrow averagely like bone marrow aspiration, I mean, like 10 in a week. Which site do you think would be appropriate? From what you have heard this afternoon, to aspirate the contents. Give example. You are going to use sternum and go into the heart, you are on your own. No. If you put the, have you seen the bone marrow needle? How big? It's not the injection. No. I'll bring it to class one day and you see how big the needle is. If you use the sternum, you go into the heart, the patient dies on the table, you lose your license to practice. So you want to avoid the sternum. So we use the pelvis. We use the anterior superior. We use the anterior superior iliac spine or posterior superior iliac spine. What vessels stand on your way that you can damage with the needle? The needle is not needle for injection. No. It's big, it's metal. Metal, you know, drill it into the bone. So you can go into which vessels are likely to be damaged. The anterior superior, your anatomy, you are forgotten. No. I'm not impressed. Some of you who claim you make distinction in anatomy, but you are not demonstrating it. Which vessels are at risk of damage if you use the anterior superior iliac spine? Vessels. Which vessels passes through here? Which vessels? Femoral vessels now, femoral artery or femoral vein. You can damage it. So what we do is to move away like 2 cm away from the anterior superior. We'll move laterally to make sure you are far away from the vessels. Because if you go and put a metal inside femoral artery, you are on your own. Patient will bleed to death. Patient will bleed to death. So we'll go 2 cm away from the anterior superior, land on the bone, and then drill the needle inside the marrow, remove the stylet, use 20 ml syringe, aspirate the contents of the marrow, and immediately make a smear. And you make a smear, you stain, and then you look under the microscope. What are we checking under the microscope? We are checking for erythropoesis, we are checking for myelopoesis, we are checking for lymphopoesis, we are checking for megakaryopoesis, we are checking for plasma cells, we are checking for foreign cells. That is a bone marrow aspiration report. We'll do a bone marrow aspiration report. And if, at my level, if I have consults from private hospital, private patient, I charge 200,000. I charge 200,000 to get the report. So, because no other person is trained. Have you heard about this before now? Even if you become a doctor, you will not have seen how a bone marrow aspiration is done. So it's only the hematologists that are trained to report, to do and report. So that's the site for hemopoiesis. So the hemopoiesis is regulated by growth factors. I've mentioned some of them. Can you give example? Erythropoietin. Another one, thrombopoietin. Another one, GCSF. GCSF, granulocyte colony stimulating. Then all the interleukins, interleukin 1, interleukin 3, interleukin 6, they all stimulate hemopoiesis. Why should the erythropoietin level be high? When you check, why should it be high? Why? If somebody's erythropoietin concentration is high, why should you think it should be high? When there's anemia, when there's a low blood level, the body will signal through a negative feedback that, oh, the blood level is low, so it's going to stimulate the kidney and the liver to produce. That's the regulation I'm talking about. So in polycythemia, the erythropoietin, will it be high or low? In polycythemic patients, erythropoietin, will it be high or low? High or low? High, say yes. No. Why should it be high? You want to be stimulating more, but somebody that has too much blood, too much hemoglobin, too much, so the system will shut the erythropoietin down. So that, in fact, that is one of the tests that confirms that a patient has polycythemia. You do serum erythropoietin, it must be low, okay, because the body would have signaled that it is producing too much red cell already, so it's going to shut down production. Okay, so in polycythemia, erythropoietin is low. So these are the various growth factors involved in regulation of so it's a negative feedback. Okay, when there is shortage of a particular cells, the body signals to the production sites of these growth factors that, okay, the level has dropped, to help us stimulate more of these cells and then stimulate production of the growth factors. Okay, and the growth factors will now stimulate the particular cells involved. Okay, so these are the interleukins I've told you. I've explained medullary and extramedullary hemopoiesis to you. Okay, so erythropoiesis, I want to start with erythropoiesis. What's the problem? Okay, so erythropoiesis, okay, so I want to come down on erythropoiesis. Okay, the stem cell pool of the marrow continually generates a supply of cells committed to erythropoiesis, one class, okay, which yield in turn a series of nucleated precursors. Okay, so we want to come down on erythropoiesis now. This undergo 4 divisions in about 4 days. Okay, we are talking about pluripotential stem cell to myeloid committed stem cell to granulocytes, monocytes, colony forming cells to erythroblasts, and from erythroblasts, what happens before you have a red cell? That's what this is all about. From erythroblasts, what happens? So they are just called maturational division. So they divide and then become smaller as they mature until they form a matured red cell. Okay, are we on the same page? Okay, so this is the process. You have the pro-erythroblasts. This is the erythroblast. Basophilic, it's called basophilic because it takes off uh, purplish stains. You can see the nucleus You can see the nucleus. So as it matures, it becomes polychromatic, lover of many colors. Polychromatic normoblasts, autochromatic normoblasts, reticulocytes, and erythrocytes. So that's the division that takes place from basophilic normoblasts to polychromatic normoblasts. So we see all these cells in the marrow. If you aspirate the content of the marrow, make a smear, and you can see maturation arrest. Have you heard about that before? No. Okay, somebody has shortage of blood, is anemic, then you do a marrow and you are seeing plenty. You are seeing plenty. These things are, very plentiful in the marrow, but they are not maturing to red cell. See, so many basophilic, so many polychromatic, and that is what is called maturation arrest. Okay, they are called megaloblasts. Okay, but because of our training, you can identify that, okay, there is a maturation arrest, and that is what is responsible for the anemia that that person is presenting. So these are the orders. There is cytoplasmic maturation. The pronormoblast is a large cell rich in polyribosome and actively engaged in the synthesis of protein. It is the earliest recognizable erythroid cell, pronormoblast. So the staining reaction changes from blue to the basophilic normoblast. So after some time, matures into basophilic. The proerythroblast mature into basophilic erythroblast, and to a lavender color, the polychromatic normoblast, lover of many color. Okay, and then mature into orange pink cells. Okay, orange pink cells called autochromatic normoblasts. Okay, and then there is a cytoplasmic maturation and there is nuclear maturation. Okay, the nucleus also matures. As it matures, it reduces in size and become more condensed. Okay, more clumped together. Okay, later the nucleus is ejected. Mature red cell lacks nucleus, has no nucleus. Mature red cell lacks nucleus. So you have eventual ejection of the nucleus before you have. So there will have the reticulocyte stage. So from the proerythroblast, basophilic erythroblast, polychromatic erythroblast, autochromatic erythroblast, reticulocytes, and matured red cell. So that is the order of the erythropoesis. Are we on the same page?
Yes.
Okay. So maturation of reticulocyte to an adult red cell is for another 24 to 48 hours. Okay. So this is a mature red cell. We know how it looks. It's a biconcave disc. Okay. And that's the diameter and that's the volume. Okay. And hemoglobin concentration of about 33. So a single pronormoblast will give rise to 16 matured red cell. Okay, so this is another diagram showing from the hemopoietic stem cell to burst forming unit erythroid, to colony forming unit erythroid, to proerythroblast, to basophilic erythroblast, to polychromatic erythroblast, to autochromatic erythroblast, to reticulocytes, and then the nucleus is evicted, and to mature red cell. Mature red cell, reticulocytes also are found in red cell, but in peripheral blood. Okay, so these are the various basophilic. This is how they look in the marrow. So we are trying to say, okay, this is a basophilic erythroblast. You can see the nucleus is large, is open, the cytoplasmic is bluish, Okay, so you can count. So these are more matured. You can see it's smaller, the cells are smaller. This one is smaller, okay, but there is a joint intracytoplasmic connection here. It's not fully separated, okay. So this is the picture of what you see in the marrow regarding. So there's what is called ineffective erythropoiesis. What does it mean? So erythropoiesis is not 100% effective. So in you and I, 10 to 15% are abnormally formed. But there are some diseases that this ineffective erythropoiesis can be as high as 70%, 80%. Mean, and they are destroyed in the marrow. So what's the implication of that? Cytopenias, okay? So you have conditions called myelodysplastic syndrome, in which the formation of erythropoiesis or myelopoiesis are abnormal, and so there is maturation arrest, and then they cannot progress, okay. So that's the kind of diagnosis we make, and then we also treat such diagnosis. So normally in a normal person, ineffective erythropoiesis is seen in between 10 to 15% of all the hemopoietic cells. That's a normal. So those 10 to 15% abnormal cells are destroyed, but you still have more than enough, okay. So ineffective or intramedullary hemolysis is substantially increase the number of anemia, like in sickle cell. So this is also about regulation, and this is the timeline for erythropoiesis. So what's the lifespan of the mature red cell? It's 120 days, as you can see. This is from the erythroblast stage. Okay, so I think this is another timeline. This is how long it takes to move from one stage to the other. Okay, and these are the proteins that are responsible for stimulating the boss forming and everything. You can see the erythropoietin. You can see this is where it start acting at the basophilic erythroblast stage. So it's going to stimulate production of cells to matured red cell. Okay, so this is another one. So thank you for listening.